All right, I'm going to go ahead and get started. I'm sure more people will be logging in shortly, but I know that Dr. McKay has a lot of information she wants to cover today. So I'll get started a little bit early here. Please bear with me. I appear to be having some computer difficulties, so I have to give you a picture of myself from close to 15 years ago to look at instead of my video. Even my slides are not making it full screen, so hopefully you can see this all. But welcome to our October meeting. Thanks for joining us today. While the pandemic may be on its last legs, we still await notification of when we may return to the SBP auditorium. So until then, with the efforts of myself, John Tassi, Bill Manning, everybody else who has helped out, we'll continue to provide information via live streaming on our regular meeting dates, the third Saturday of each month. The principals of our organization are Bill Lewis, the president, who also does the newsletter summaries. Jean Van Vliet, our director and treasurer, Steve Pendergast, our secretary and newsletter editor. I hope you got a chance to see our newsletter this month. It really has a huge amount of information in there that, especially for me, hits close to home. Bill Manning is our director and videographer. Myself, Aaron Lamb, the director, and the facilitator of the meetings, and John Tassi, who is our webmaster. And of course, there's you. We have over 900 members, and everyone is a volunteer. You can be too. So our support to you comes in the form of our website, www.ipcsg.org. And there you can find all of our newsletters. Of course, there's also the link to the monthly video streaming on the third Saturday of each month. And perhaps the most important thing that might be of use, especially to new patients, is our hotline. You can see on the slide, it's also on the website. And that's the hotline to get in touch with one of our directors, Gene, that monitors that line. And he can then put you in touch with somebody who can help you get the answers to any of the questions that you might have. We're always looking for more volunteers to help out with that hotline. So please do get a hold of Gene if you're willing to help out. We've definitely seen an increase in the calls to the hotline as people get more comfortable with going back to the doctors and have started to, I guess there's been a surge of diagnoses. So of course, our call for volunteers. We need help from people to recruit doctors and other specialists and to schedule the speakers. We would like other people to perhaps share their experience. Typically once or twice a year, we do a roundtable with 3 of our members, and they discuss their history of treatment. That is a very important piece of helping our other members. It happens to be the meeting that I attended for my first time, and it was really reassuring to see a lot of other people going through the same thing as me and where they were at the end of their treatment. And of course, as I mentioned, we need volunteers to help with the hotline calls. So please contact us either through the website or the hotline if you're willing to help. So our support group purpose is that we share our patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, and we are not medical professionals. So any sharing by any one of our group may not be substitute for your own medical counsel. And additionally, we need your support. We are a 501c3 nonprofit organization, so donations are tax deductible. We have no medical or religious affiliations. And during the coronavirus pandemic, our video streaming, and we are video streaming our meetings, our costs remain very much the same. We have a lot of costs for advertising, for keeping our website up and running, for having the Zoom meeting a license, etc. So please do make a donation to us. You can do that on the website via PayPal, or you can send a check to the address that you see there. And that address is also available on our website. As for today's meeting, we have my own oncologist here today that I love to both talk to and have come in to have to hear what she has to say at our meetings in the past. So she'll be giving a talk on the recent advances in the care of patients with prostate cancer. Dr. Rana McKay, please take it away.
Thanks so much, Aaron. Really appreciate the introduction, and great to be here with everyone. So let me share my screen, and then we'll kick it right off.
And I forgot to mention, please, everybody, feel free to submit questions by way of the Q&A function. And we'll have answers to all those questions at the end of the presentation. Yeah,
that sounds great. Yeah, can you guys see the screen?
Yes, we can.
Perfect, great. So yeah, we'll try to take questions at the end, and feel free to chime in if there's anything that you all need. All right, so we'll dive right in. Talking about recent advances in prostate cancer. We're gonna go through genetic testing for patients with prostate cancer. We're gonna talk about novel imaging. And then last, we'll talk about some recent therapeutic advances. And I've really tried to make this presentation in the eyes of you as patients so that you can understand sort of, so there's a lot of medical jargon, and I really wanted to try to break that apart, okay? So first we'll go through genetic testing for patients with prostate cancer. So the first question when we talk about genetic testing, and I'm just gonna take it all the way back, presuming that everybody on this call, I know you all are very informed, but just taking it back to the basics of what are genes. So genes are pieces of DNA that are inside of our cells that tell our cells how to make the proteins that the body needs to function. You can think of genes as a genetic blueprint in each cell. It's kind of like the Rosetta Stone for what your body, our bodies need to make and function. And they're transcribed, into RNA, which we take all of our genetic code, and you've got, lots and lots of information in the genetic code, some information that's needed, some information that's not needed. That gets made into RNA, which is then distilled down into kind of like, what do I need to make? It's like you've got your, almost like, not to say your Cliff Notes version, but it's almost like this is the need to know to make the protein, and then it gets translated into protein. And genes affect inherited traits that are passed from parent to child, like hair color, eye color, height, and they can also be implicated in diseases if certain patients, certain individuals have genes that are associated with a specific disease. So that leads us into the next question of, well, what are mutations? And mutations are changes in genes that can play an important role in the development of cancer. Mutations can cause a cell to make or not make proteins that affect how a cell grows and divides. And so, here's kind of a little schematic that, the genes, when they're functioning normal, make normal protein, but if some gene is not working correctly, it affects the way that the protein is made. So there are different types of mutations. So we talked about genes, we talked about mutations, and there's different types of mutations. And the way that I like to break down mutations are, they can be acquired mutations, or another word that we use in the clinic sometimes is somatic, or they can be inherited, which means you were born with them. They're germline, okay? Somatic mutations are acquired, normal prostate cancer cells may develop a mutation that then causes that cell to become a cancer cell. Or certain cells can be born with a predisposition to become cancer cells. So somatic mutations are more common. They're not inherited. They occur in non-germline tissue. So that would be your, most of the cells in your body. Whereas germline mutations are present in egg and sperm, they are inherited, and they can cause familial syndromes. So what is genetic testing? So genetic testing are tests that we can use to try to identify certain mutations in a person's genes. And the tests can be used to identify inherited or acquired mutations. So either mutations that somebody was born with or that their cancer has developed. And usually testing can include specimens from the actual tumor itself, blood, saliva, and in some rare cases, urine. The technology is getting really good at trying to even to detect, tumor DNA in the urine, but we're not quite there yet totally. So there have been guidelines now for men with prostate cancer around genetic testing. And the reason these guidelines have been developed is that there have been studies that have been conducted in large cohorts of men with prostate cancer that have identified that approximately 5 to 10% of men with prostate cancer are born with a hereditary predisposition for prostate cancer. And for patients with advanced disease, there's a subset of individuals who have mutations that are acquired in the tumor that could potentially be targeted by specific drugs. And so now there are recommendations for genetic testing for men with prostate cancer. So the recommendations include for people who have localized disease that's high risk, or they have a family history, there's a recommendation for germline or inherited genetic testing. For people that have recurrent or advanced disease, there's a recommendation for both inherited germline testing and also acquired somatic tumor testing. So things that are in the tissue, in the tumor itself. So delving into that a little bit more carefully, because there are some nuances there. So the patients who are recommended for germline testing, and this is again inherited testing, would be those that have metastatic, regional, very high risk or high risk localized prostate cancer. If patients don't fit into that category and they're either low risk or intermediate risk, the testing for those individuals is really largely driven by a concurrent family history. Or anybody with a personal history of breast cancer should be tested for a germline genetic syndrome. Other considerations can be for individuals that have intraductal or cribriform histology, independent of their cancer risk status, should be considered for testing. So why get tested? The reasons to get tested is one, it could potentially inform targeted therapy options for patients with advanced disease. Targeted therapy options are not for everybody. Again, it's more so for people who have advanced disease. It can, so here's sort of the shift, the paradigm shift in treatment. And this is the whole concept of precision medicine, where instead of having sort of a one-size-fits-all approach where we give everybody the same drug that may have a certain, type of cancer, there's still utility in that for a lot of patients, but precision medicine is basically trying to identify who in that mix may benefit from any one given drug. And we can use disease parameters and clinical parameters to help discern that, but also we can use genetic testing results to help us better stratify patients for any given therapy, okay? The next reason to get tested is it can inform cancer screening options for patients that are tested. So for example, if you are positive for a germline genetic syndrome that's associated with a cancer syndrome, there may be indications for skin exam to check for melanoma, mammogram, colonoscopy to check for other types of cancers that could happen with that syndrome. And it can also inform cascade testing for first-degree relatives. So what that means is that if you have a germline genetic aberration, then there's a risk that that can be passed on from generation to generation. And so it becomes important to talk to first degree relatives, whether that be children, brothers, sisters, about, getting them tested as well to identify if the gene has been passed on. And there's a lot of discussion around that, when's the right time to test, and if somebody does get tested and they're positive, when to screen and how to screen for different cancers. So it's really important for anybody that has a positive mutation to really be doing this in the context with a genetic counselor. So just to kind of go through a little bit for inherited germline testing, what kind of results may you receive if you were to perform, if such a test were to be performed. So the results can either be positive, negative, or what we call a VUS, or variant of uncertain significance. A positive result is the least common result. It is most of the time when we do this test, the likelihood that it's going to be positive is at max 1 in 10 or 1 in 20. So it's not very common. If it is found, then usually we refer to a genetic counselor. The most common result is actually a negative result. Most of the time when we do the test, it's negative, but it doesn't mean that we shouldn't do it, but most of the time it's negative. Sometimes what we see is a variant of uncertain significance, meaning we find a variant and it's never been described or associated with cancer, but there's just not a lot of information on it. So we can't call it a true negative. And most of the time, this tends to come up in patients who have like non-European heritage. And the reason why that is a lot of the genetic testing that has been done thus far has honestly largely been conducted in a lot of white males. And so when there's ethnic diversity, we tend to find a little bit more VUSs. It doesn't mean that they're bad. It just means that some of these things, we just don't know what they mean. Around 95% of VUSs down the line get reclassified as benign. So most of the time, there's nothing to do about a VUS. The only time really I think of referring somebody to genetic counseling when they have a VUS is if they have a really concerning family history that I'm worried it could be potentially real. Now, so that was the germline genetic testing results. Well, what about somatic testing? Somatic testing, again, is in the actual tumor itself, not what you were born with, but what's the mutational profile in the tumor. And this kind of breaks down into these 3 buckets. Now, there's lots of different buckets. Some of you guys may have undergone genetic testing before, and you get these reports, and they're sometimes hard to interpret. But the way that I like to break them down is there's biologically relevant and they're actionable. There's biologically relevant and they're non-actionable. And then there's VUSs. So the biologically relevant that are actionable, those would basically be drugs or mutations that we can potentially target with a specific therapy. Sometimes these mutations may also inform outcomes. There's both biologically relevant that are non-actionable, and a lot of times these are more used to help inform prognosis. How do we think you're going to do overall? And then in this case as well, there are also VUSs that we're just uncertain of their significance. And quite frankly, we don't really do much with the VUSs. They're not very helpful with deciding about prognosis or treatment. So the landscape of alterations in prostate cancer has really been, being realized based on a lot of studies that sequence large numbers of patients to understand what are the pathways that are altered in prostate cancer. So this is just a schematic that highlights some of the key pathways that tend to be altered. The androgen receptor pathway continues to be altered in a very large percentage of patients, and which is why androgen deprivation therapy remains the cornerstone of treatment for patients with prostate cancer, given that a large proportion of patients, really have alterations in this pathway. The DNA repair pathway is becoming increasingly important, and there are certain drugs that can be used to block that pathway. And we're learning there's kind of this long tail on the curve of sort of, rare alterations that can happen that can still be clinically significant. And even though if you look at each one of these alterations in and of itself, they're rare, when you sum them up, they're actually in totality common. So the next phase that I want to talk about is next novel imaging for patients with prostate cancer. So there's been a lot of excitement around imaging, new imaging tests, and I want to kind of try to distill this down for all of you. So you may have heard that there's PET imaging that is now available for patients with prostate cancer. So I wanted to describe what is PET imaging. So PET imaging is an imaging test that can help reveal the metabolic or biochemical function of a tissue or organ. And it detects pairs of gamma rays that are emitted indirectly by a radionuclide. And it is a functional test, not an anatomical test, meaning it detects sort of metabolic activity, not where is something exactly. Usually PET imaging tests are conducted in the with a CT scan or with an MRI that tell us anatomy. If we look at a PET scan, it usually by itself, it just looks like a black sheet of paper with some dots on it. And we have no idea where those dots are unless we overlay that picture on a CT scan or overlay that picture on an MRI. So that's why a lot of times you see the nomenclature of PET CT or PET MRI, because they're usually paired together. Now, with regards to, the PET compounds, so there's, these molecules have a radiotracer and a target. And when we're talking about these molecules, there's different kinds of radiotracers and there's different kinds of targets. So the different kinds of, and they can be mix and match per se. So the different radiotracers, and the radiotracer is basically the light. What is the light source? You could think, what is going to show up? And the target is going to be, what is it going to bind to in the body to cause it to show up? So you've got carbon-11, gallium-68, fluorine-18, copper-64. Those are the common radiotracers that are used in PET imaging studies. Then you've got targets. So there's FDG PET. That's the historic kind of like PET scan that you may think about kind of just for general cancer screening, not specific to prostate. And that's a type of glucose analog. Then there's choline, fluciclovine, PSMA, sodium fluoride. So there's all these different targets, okay? And the target is linked to the tracer via a linker. So again, talking a little bit more about these isotopes, what's interesting about the isotopes is they all get made in different kind of ways and have different kind of half-lives. And why that's important is because if something has a very short half-life and it's going to rapidly decay and lose its signal, it really gets important with the production of the product. So the example is gallium-68, for example, has a very short half-life. That basically means that gallium-68 needs to be generated on site at any facility that is doing gallium-68. So, it's not something that can be made regionally and then shipped to a site. The site has to physically make it itself. So gallium-68 has actually been quite limited. For example, gallium-68 PSMA, it's readily available at UCLA, UCSF because they have a generator on site to make the gallium-68, but they can't ship it because it's gonna decay. It's gonna not be effective. Whereas fluorine-18, F18 scans, for example, and there's F18 PSMA, they're made in a little bit different kind of way. It's made through a cyclotron. It has a much longer half-life, so it can be made at a regional site and shipped around. So it's easier to commercialize the product. And I think the reason I highlight this is because this is going to speak to a little bit about some access issues around these radiotracers. So FDG targets a glucose analog. Choline targets a cell membrane lipid biosynthesis analog that's in the membrane of cells. Fluciclovine targets an amino acid analog. PSMA targets a transmembrane protein that's expressed on cells, and we'll talk about what PSMA is. and sodium fluoride is bone targeting. So each of these things targets different parts of the cell or parts of the body. So what is PSMA? So PSMA is a transmembrane protein that is expressed in prostate cancer cells, and it has about 100 to 1,000-fold higher expression in cancer tissue versus benign tissue. And it tends to have increased expression in higher grade tumors and hormone-resistant tumors. Not all prostate cancers express PSMA, but a lot of prostate cancers express PSMA. So here's an example of a 69-year-old man whose status post a radical prostatectomy and had a PSA level of 0.67 and had a PSMA scan that was performed that showed that he had a spot in his right humerus that you can see here lighting up on the PET scan, and also a spot on the left internal iliac node on the bottom panel. And you can see why we like to overlay the PET images with the CTs, because they really help us figure out where exactly things are in the body, as opposed to this sort of gray mush here on the far right, okay? This is a slide that denotes sort of what are some of the differences between PSMA and fluciclovine. So the top panel is a fluciclovine PET, and the bottom panel is a PSMA PET. And you can see that the background noise in the top panel is still pretty substantial, and the max SUV for what is detected, there's still a difference from the background, but it's not as dramatic as what we see with PSMA, which is a little bit more specific. So the background noise is at 0.6 SUV, and the target here is at 33.4. So it really helps with visibility. Here's another example of an area kind of within the pelvis, okay? Now, this is all nice, but there can be false positives with PSMA PET, and I really want to highlight that here. There can be false positives, with rib lesions in particular. There can be false positives with the nerve roots of the presacral dorsal ganglia. These are kind of nerves. It's common to have, there's ganglia all over your body, and sometimes these can light up positive, and they don't necessarily mean that there's disease there. Hemangiomas can sometimes light up positive, but it doesn't mean that they're there. Paget's disease, other tumors can light up positive sometimes. So while it's a good imaging modality and is going to be integrated into clinical care, there's always a lot of gray in medicine, and there's no one test that has 100% specificity and 100% sensitivity. So you may have all heard about the fact that PSMA imaging is now FDA approved. So the gallium-68 PSMA that I talked to you about is FDA approved. That was as of December of 2020. And then the FDA has also approved the Polarify F18 PSMA scan. And it's likely that F18 is going to be what becomes commercially available at various centers. And we actually now have PYL F18 PSMA at UCSD and have been scanning patients already over the last month. So the next list of topics is going to be around recent therapeutic advances for patients with prostate cancer. I'm going to talk a little bit about lutetium PSMA. I'll talk about olaparib and rucaparib. We'll talk a little bit about relugolix, and then some clinical trials. So a lot of data here. It may get a little bit confusing, but I'm going to try to distill it down and keep it very pertinent. So lutetium PSMA, what is this? This is basically a targeted radioligand therapy. So on one side, it targets and binds to PSMA, and then there's a beta particle that's attached to that target that binds onto the cells. And that beta particle emits a little bit of beta radiation when it, what happens is when this molecule binds to PSMA on the cell membrane surface, it gets endocytosed, meaning it kind of gets taken into the inside of the cell. And because there's a beta particle that's attached to this product, it causes DNA damage within the cell. And most cells, when there's a sufficient amount of DNA damage, it causes an auto switch for the cell to die. And so this is how this drug works. There was a large study called the VISION trial, which tested the efficacy of lutetium PSMA compared to standard of care therapy. And in a lot of scenarios, this was really compared to best supportive care. Probably about 20% of patients that were in this group weren't really on any anti-cancer therapies. And this trial was designed in patients who had received a prior hormonal agent and had received prior chemotherapy. And the primary, I'm just going to share with you the highlight points. There's a lot of nuances about this trial, but I won't necessarily go into all of that. The trial did demonstrate a statistically significant improvement in overall survival with lutetium PSMA, 15.3 months compared to 11.3 months. So patients did live longer with the addition of lutetium PSMA. And then when we look at secondary endpoints, we also saw responses in the tumors. When we measure the tumors and see if there's shrinkage, the yellow is standard of care, the blue is lutetium PSMA, and the complete response rate was 9.2%. The partial response rate was 41%, 42% here. The progressive disease rate, meaning it just didn't work at all, was around 13%. And then here are the PSA responses. So the blue again is lutetium and the yellow is standard of care. And the middle line here is 0. So you can see the percent of patients that had a decline in PSA. So 33% of patients had a greater than 80% decline in PSA. 50% or 46% of patients had a greater than 50% decline in PSA. But there was still about a third of patients that you can see here that even though they got lutetium PSMA, their PSAs continued to rise. So again, this therapy is not necessarily for everybody. It is effective and better than standard of, this was the standard of care. And like I said, in most cases, best supportive care, but it's not 100%. And this is the side effect profile of the medication. The biggest thing is fatigue at 50%. It can cause bone marrow suppression, also around 50%. Nausea, vomiting, dry mouth can occur about 40% of the time. There can be some kidney toxicity, so those numbers get monitored around 10% of the time, 8.7. So these are things to kind of watch out for. So the FDA has not yet made a decision around lutetium PSMA. I think that will be forthcoming in the next several months. We're going to have to wait and see what the indication is for this compound. It's most likely going to be in the advanced CRPC setting, most certainly after an AR targeting agent. We're not sure whether it's going to have required prior chemo or not, but we will await and see what the FDA rules on this compound. So next we're going into the PARP inhibitors. So PARP inhibitors are drugs that affect the way the cancer cells or any cell really repairs DNA, DNA damage. So they really impact the ability of DNA to fix single-strand breaks. And really where they've shown efficacy are in patients who are BRCA mutated. So for patients who are BRCA mutated, BRCA is an important gene required to fix double-strand breaks in the DNA. So when patients have a BRCA mutation and you give them a PARP inhibitor, they are not at all able to repair their DNA. And the cell, again, has this signal in it that tells the cell to die because the cell can't repair its DNA. So in a normal person who takes a PARP inhibitor, generally it doesn't work by itself as a single agent. But in somebody who because they can basically repair their DNA through BRCA and other types of pathways. But in somebody who's BRCA mutated who can't repair their DNA, You give them a PARP inhibitor, which induces a little bit more DNA damage, and then they really can't repair their DNA, and that's how these drugs work. So there was a large trial called the PROfound trial that tested the benefit of olaparib for patients with advanced prostate cancer. Basically, patients were randomized to olaparib 2-to-1, either olaparib or physician choice of either abiraterone or enzalutamide. And there were 2 cohorts, patients who had BRCA1, 2 or ATM alterations, and then patients who had other DNA alterations. And you can see the listing of the different genes here that were included. And the primary endpoint was radiographic progression-free survival. And the trial was positive. It demonstrated, it delayed the time to progression for patients who were treated with the PARP inhibitor compared to control, 7.4 months compared to 3.6 months. And also, it improved survival as well in these patients, okay? There were also data from a study called Triton-2 with a different PARP inhibitor called rucaparib. This was a single-arm study looking at the activity of rucaparib in patients who had DNA repair alterations and demonstrated, I'll show you here on the next slide, a significant, tumor responses in patients who were BRCA1, 2 altered. And because of the results of these 2 studies, the FDA has approved olaparib and also rucaparib for the treatment of advanced prostate cancer for patients with homologous recombination repair deficiency. So shifting gears, we're going to talk about GNRH targeting drugs. So this is the backbone of therapy for patients who have advanced prostate cancer. Classically, we use LHRH receptor agonists that target LH production within the anterior pituitary gland. Both LH and FSH go to the testes to cause it to make increased testosterone, and that can fuel prostate cancer growth. So the way the LHRH receptor agonists work is it's kind of like the boy who cried wolf. You kind of like keep hitting the receptor, and then it basically turns off. You basically shut it off. You kind of keep your finger on the doorbell, and eventually the doorbell stops ringing. And so that's basically how these drugs work. Whereas the GNRH receptor antagonists, they actually block the pathway from the get-go and result in declines in both LHRH and FSH, and testosterone kind of not getting made. So the HERO trial was a randomized phase 3 trial, which was testing the benefit of relugolix compared to leuprolide acetate. Relugolix is an oral GNRH antagonist versus leuprolide, which is a LHRH agonist. The primary endpoint of the study was basically sustained castration at 48 weeks. So what were patients' testosterone levels at 48 weeks? And so that was the primary endpoint of the trial. And the trial did demonstrate that use of relugolix did result in sustained castration at 48 weeks. And one of the key secondary endpoints was that it dropped testosterone levels lower than Lupron. And in fact, it did. It did drop testosterone levels lower than Lupron. So actually, testosterone levels get to be lower with relugolix than with leuprolide. For patients who are getting intermittent hormonal therapy, or maybe the people that were enrolled on this trial were people who had already had their definitive prostate cancer therapy, and then were intended to be on hormone therapy for a year or more. When they stopped therapy, they also measured people's testosterone, and it did seem that testosterone recovery was a little bit quicker with relugolix than it was with leuprolide for patients who had been on therapy for a long time. So thinking about the adverse side effects with this drug, hot flashes, when you compare to leuprolide, 54% compared to 51%, fatigue, 21% compared to 18%, constipation, diarrhea was a little bit more with the relugolix, almost double that with leuprolide. So all of these kind of parameters from a fatigue, hot flashes standpoint, because you're actually resulting in lower testosterone levels with the relugolix compared to the leuprolide, maybe a little bit more, about the same, a little bit more compared to leuprolide. What did come out in the trial, and this was not planned in the context of the trial, this was something that they observed after the trial was conducted, the trial was not designed to specifically look at cardiovascular events. It appeared that relugolix was associated with decreased cardiovascular events. Now, that being said, the number of events was still pretty low. So while it resulted in a 50% reduction in events, the number of events were low. So the number of cardiovascular events with relugolix was 2.8%, but with leuprolide was 5.6%. So yeah, that's a 50% reduction, but the rates of any cardiovascular event are 5% and less. So the rates of these events was actually quite low. So because of this data, the FDA has actually approved relugolix as an agent. There's really not a lot of data regarding combination with other agents, combination with abiraterone, enzalutamide. There were probably less than 20 patients who had received enzalutamide with this trial. There's really limited published data regarding combination with abiraterone or chemotherapy or some of the other drugs we use to treat prostate cancer, though that data will likely be forthcoming. So the next thing that I'm going to talk to you about is PSMA CAR T. There's been a lot of excitement around PSMA CAR T and CAR T therapy in general. So what CAR T therapy is basically re-engineered T cells to basically target a specific protein within a cancer. So the process for this is we would, harbor T cells from a patient's body through a process called leukapheresis, where you're kind of hooked up to a machine and there's a reverse blood transfusion that happens almost, where we take out some of those T cells. Those T cells go to a company, Poseida, who is leading a lot of these efforts, and they're re-engineered so that they can actually express a certain protein. They're re-engineered so that they have a gene that can express a certain protein that targets the cancer. And in this case, it's PSMA. And then you basically, your immune system is one of the greatest defenses that you have against, foreign things within the body. And so you basically train the T cells to fight off PSMA expressing cells. And with this, there's a lot of different CAR Ts that are out there. With this CAR T, it's a non-viral gene insertion technology. And with a non-viral gene insertion technology, it can allow for more stemness to the cells, so the cells can be around for a longer time, continuing to fight off the cancer after 1 or 2 infusions. There's been some very preliminary data that have been presented thus far of the first 9 patients that have enrolled on this trial. This trial is open at UCSD, and we've seen some impressive results. 5 patients have had declines in their PSA. 3 patients have had declines in their PSA with, that was at least 50%. And there were a handful of patients that also had a resolution or improvement of PET uptake on PSMA scan. So I think it's encouraging, but it's still very early days, but this is a trial being conducted for more advanced patients. The other drug I'm going to tell you about is CCW702. This is a bispecific antibody to PSMA. You can see it's a pretty large molecule. On one side, it targets PSMA, and on one side, it targets a T cell. So it basically brings the T cell in close vicinity to the cancer cells to allow the T cells to fight each other. And this trial is currently accruing patients and is also open at UCSD. We will be having another trial that's soon to be open of a drug called serumtuzumab with docetaxel chemotherapy. Serumtuzumab is a monoclonal antibody that binds to ROR1. ROR1 can be expressed in prostate cancers and can be important in the progression to neuroendocrine prostate cancer. And so this is a way to prevent that, basically to try to treat that. And so this trial will be opening soon. And there's another trial called the COSMIC-021 study looking at the combination of atezolizumab and cabozantinib. These are one's an oral agent agent that targets VEGF. One's a immunotherapy, and there was some promising results for patients that were enrolled on the phase 1, and now there's a large phase 3 that's currently ongoing. So 70% of patients, 77% here, had regression of their tumors based on with the combination therapy. There was some data that were presented around VERU 111. This is basically a oral microtubule inhibitor. It's similar to docetaxel in what it actually does. It's like again, affects the microtubules within the cancer cells. There was some early data presented, but this drug is being tested in the large phase 3 setting. So that kind of summarizes, there's been a lot of advances in genetic testing and PET imaging tools, lots of drugs kind of in development for patients. And so, I think our patients are living longer and living better because of these things. And I will stop there and take questions that you all may have. I'll go to the question answer. So the first question is, your name came up in our SWOG GU annual meeting for a new clinical study. Can you offer any details? So I am not certain, because there's lots and lots of trials. With regards to prostate cancer, the one trial we're working on through the cooperative group is a trial called PREDICT. It's a trial where we are trying to target therapy based on specific mutations within the tumor, but that trial is still pretty early on. My suspicion is it's going to be a year and a half away before it were to open up, but that is being developed through the Alliance Cooperative Group. Will gallium PSMA be available in the future at UCSD? Potentially, but honestly, we already have PYL PSMA. And the only difference between gallium PSMA and PYL is just the radiotracer. And the half-life of the radiotracer. There have not been studies comparing gallium PSMA and PYL PSMA, but in essence, F18 has already been validated as a very active radiotracer, not just for PSMA, but for PET imaging tools in general. You can see that gallium is not used for any of the other PSMA tracers. It's really only used, or not PSMA, for all the other tracers. Like there's no gallium FDG or gallium, choline. It's just not readily made. But I do think in the future it will be available, but we actually even now have PYL available.
Yeah, Dr. McKay, if I can jump in there.
Next question is, what in your opinion regarding the use of metformin with ADT to minimize metabolic syndrome? So yeah, I think that there's a lot of mixed data around metformin. And in somebody who does not have any metabolic syndrome risk factors, adding metformin, like if you're in great health with good cholesterol, good hemoglobin A1C, you exercise regularly, adding metformin, the studies have demonstrated, does not necessarily impact prostate cancer, survival or growth or anything. And metformin, quite honestly, can be associated with some, fatigue and GI toxicity. It's not necessarily just an easy drug to be on if you don't need to be on it. But in patients who are at risk, obesity or maybe some prediabetes or, at risk of metabolic syndrome, I do think it can potentially be helpful. But I wouldn't just give it to any healthy person going on ADT just because of the sheer fact that they're going on ADT. So the next question is, what, in your opinion, regarding a paradoxical response with second generation ADT, where PSA decreases, but the cancer progresses? So, I think this question really gets at, there's a lot of resistance pathways for patients with advanced hormone-resistant prostate cancer. And in the context of patients having advanced hormone-resistant prostate cancer, it's not only about the androgen receptor pathway. There's a lot of other pathways that are important that can cause a cancer to grow that are not directed by the AR pathway. And so there can be scenarios where a PSA is declining, but the cancer is progressing. They're not very common. We tend to see them when patients transition to a neuroendocrine differentiated prostate cancer. That doesn't happen in everybody. We probably see it in 15 to 20% of people with advanced prostate cancer. But, those are the scenarios where we do see it, where maybe they're on a hormone therapy and the hormone therapy is working, but they're actually having progression because the neuroendocrine component that doesn't make PSA is growing. But it's pretty rare, and I think a lot of people are afraid of that happening. But it's a pretty rare phenomena, and it is typically something that occurs in late stages of the disease and not early on, and not for people that haven't seen sort of a lot of different drugs to treat the cancer. Okay. The next question is, what, in your opinion, regarding the use of chemotherapy as a primary therapy for recurrent prostate cancer in conjunction with ADT? So, this question gets at data from Charted and Stampede around the early use of chemotherapy. And quite honestly, about a month ago at the ESMO meeting, there were data presented from the PEACE-1 trial for patients with newly diagnosed, high risk, metastatic disease, actually doing the triplicate of docetaxel, abiraterone, and ADT to improve outcomes. And survival was dramatically improved in the patients that got the triplicate. But again, it was people who are really high risk. So in my role for people, with regards to people who have recurrent disease, I think it really depends on their risk status and their burden of disease. Are they low volume, high volume? What's sort of going on with their disease regarding the trigger around chemotherapy. But I do think that early chemotherapy does make a subset of patients with prostate cancer live longer compared to not doing that treatment intensification. Okay, the next question, what is the wait time for PYLARIFY PSMA at UCSD, and what is the approximate out-of-pocket cost for the procedure? Also, where is the PYLARIFY site in Culver City? So I think that we just kind of started ramping up. So there's actually, not to say a lot of spots, but it's probably a couple of week wait time for PYLARIFY. It's not 6 weeks, but it's like 2 to 3 weeks, I think, wait time for the PSMA. The out-of-pocket costs really depend on what somebody's insurance is. We've had really good success with coverage for patients who have Medicare. But for patients with private insurance, it's really variable. So, it's hard to know. Does UCSD's PYLARIFY imaging require certain prostate cancer stages? So it's not UCSD's requirement, but actually what is your insurance company's requirement? So where these agents have been approved, largely where we have the least resistance with getting them covered is people who have had definitive treatment with a rising PSA. That's generally where they're covered, but we try to, it's not a UCSD thing, it's more of an insurance thing and what the patient is gonna end up paying. Not to say we'll image anybody, but it's not our decision to make, okay? I think those are all the questions. It's been really great chatting with everybody today. Hopefully, oh, nope, there looks like there's another one that popped up here. Is carbon 11 used anymore? Not really. And I answered that question. Oligometastatic disease after radical radiation, does new imaging enable? Yes, it can. Yeah, so we have been trying to use spot SBRT to treat oligometastatic disease. We don't really have data on how that improves long-term outcomes, but it is something that we're integrating into care. Okay.
Yeah, that was a huge amount of information. Thanks so much. I know that obviously from the Q&A that you saw, there's been a lot of recent questions about the PYLARIFY that recently has been enabled. So it sounds to me as though a patient's choice of getting the gallium-68 versus the PYLARIFY really is not important in terms from the medical standpoint. It's more of just get the one that you can schedule the soonest, would you say? Is there really a a significant difference.
There doesn't appear to be an appreciable difference between gallium-68 and PYLARIFY. So
Perfect.
I don't think that there is, I think if there's a PSMA test that is indicated for any given patient, I don't think that one is better than the other.
All right, that's great to hear, because I know one person at least was being pushed into December for trying to get an appointment at UCLA for the gallium-68, but sounds like they could do better here. I think UCSD is just as you said, a couple weeks out on schedule. Right. So wonderful. Were there any names of the specific genetic tests that you suggest?
So I like to use either Caris or Tempus. Actually, I've just recently transitioned over to doing a little bit more Caris testing because they actually end up doing more broad genetic testing than I think some other vendors. So, I think a good comprehensive test is really what is needed. That's only for somatic tumor profiling. For germline, we tend to use Invitae, but Ambry, others can be used as well.
Gotcha. And since more and more information is being added to, I guess the results of those tests, is there any kind of periodic review of like if I had my test done 4 years ago, would I automatically receive any update of actually one of those mutations that we didn't identify before has recently been identified to have new information behind it?
Yeah, so if that were to be the case, what would happen is they would issue a new report. It doesn't happen very often, but if there was a VUS that was found to be benign or found to be pathogenic, they would issue a new report to the ordering doctor and say, this is the new information that we had. So the companies that do this, it's part of sort of what they do. Yeah.
All right. Excellent. Well, I think that's it for my questions.
Great.
Yeah. Thanks so much for all of your time.
You're welcome.
I really appreciate it. Take care, doctor.
Of course. Bye-bye.
Bye-bye.